All right. Hi, good evening, everyone. My name is Beverly Chang, one of the co-founders of the Tri-State Obesity Society of New York, New Jersey, and Connecticut. Thank you for joining us this evening. I want to welcome Polly DeMille from the Hospital for Special Surgery. She is an exercise physiologist and the Director of Performance Services at HSS. Polly has earned her master's in exercise physiology from Adelphi University and first started her career as an ICU nurse. She then transitioned into becoming a clinical exercise physiologist through the American College of Sports Medicine and is also an NSCA certified strength and conditioning specialist. Polly oversees all aspects of performance programming, from sport-specific analyses to metabolic testing to training clients across the spectrum of age and ability. Her research interests focus on bridging the gap between injury and return to peak performance, and she has authored numerous chapters, journal articles, and presented nationally on this topic. Polly has also made a number of appearances in national media, serving as an expert on the science behind fitness. Thank you, Polly, for joining us this evening. I'm going to go ahead and stop my share so that you can share your screen.
All right. Okay. Can everybody see that?
You're great.
Good. Okay, perfect. Thank you for inviting me, and thank you for joining us tonight. As Dr. Chang said, I'm a registered nurse and clinical exercise physiologist. So hopefully tonight I can give you an idea of what clinical exercise physiologists do and how we might be a beneficial member of the healthcare team, and kind of give you an overview of how we look at exercise and prescribe exercise. And hopefully it's not just a review of your, basic physiology that you already know, but a little different slant with exercise. So first of all, just to go over what we are. Clinical exercise physiologists are healthcare professionals who have academic degrees in ex-phys from accredited colleges or universities and are certified by an accredited organization. And our scope of practice really involves 4 areas: promoting health and wellness, preventing illness and disability, restoring health, and helping athletes reach their potential in sports training and performance. So really across the spectrum, from using exercise as a therapeutic modality in a disease state to prescribing exercise to reach peak athletic performance, is where an exercise physiologist comes in to determine the best exercise prescription for that individual. And if you look at the Department of Labor, clinical exercise physiologists are stratified along with physical therapists, OTs, recreational therapists, and so forth. I think what's confusing to people trying to refer out to somebody to help in this manner is just that the fitness industry is an absolute no man's land. There is zero, there's no licensure, there's no regulation really. So pretty much anyone can be a fitness professional. And really 99.9% of any kind of training certifications don't require that you even demonstrate that you've graduated from grade school. They're mostly online. Many organizations like health clubs will have one guy there who can pass the test and he takes it for everybody. So there really is, you just don't know what you're getting. So there really is one organization that requires a college degree in exercise science in addition to practical experience in order to sit for the certification exams. And the American College of Sports Medicine has various levels of certification, some requiring a bachelor's degree and some graduate work in exercise phys, but also practical experience, hours of documented experience. So when you find somebody with ACSM certification, you can at least be assured they have some academic training in the field. And if you go to their website, they have what they call the Pro Finder. So if you're in an area and you're looking for somebody that you'd like to refer to, you can enter a location, a zip code or whatever, and they can identify people in your area that have attained ACSM certification. And that's, I think, where we really can come in, is translating the recommendation to exercise into actual, how do I do this? How do I get started? So this is an example of a prescription that was created for physicians to give their patients to get them to exercise. And this originally, I think this one was used at the Kaiser system out in California for a while. And really, there is nothing more powerful than having your physician write you a script to exercise. People are way more likely to do it when their physician is telling them, okay, you've got to do this. But you could imagine if you were older, overweight, had arthritic knees, and you hadn't exercised in like 30 years, if your doctor gave you this, you might be somewhat daunted. If we look at the aerobic activity, okay, so what are your options here? Walking, well, my knees hurt, and I don't live anywhere where there's sidewalks. Running is out of the question. I haven't been swimming in the past 40 years. I don't know how to ride a bike, or I think I'm going to fall off, and I don't have a home bike. So some of those things are kind of like, well, how am I going to do it? And then if you look at strength training, these are admirable recommendations. Truly, the first 3 bullet points, like, great. Muscle strengthening exercises should be done at least 2 days a week. Let's do all the major muscle groups. And for every exercise, 8 to 12 reps are appropriate. But then look at the examples they give. Push-ups, pull-ups, sit-ups, and lunges. I mean, those are relatively high-level exercises for anybody. I mean, how many of you guys can do pull-ups? So if you're talking to somebody overweight and deconditioned, and those are the examples you give them, they may kind of feel like defeated just thinking about, I don't even know how to address this. And that's where we come in and we can be helpful here. So when we are referred a client, the first thing we do is just pre-exercise clearance, meaning, is there any, cardiac, medical, or orthopedic issue that would indicate to us that exercise might be either exacerbate a condition or be risky. We also want to find out what that individual's goals are. What are they hoping to achieve? What are their reasons for coming to us? And then what's also helpful is finding out what they've done in the past that has worked and hasn't worked. Is there sort of an exercise routine they ever followed, any form of exercise that they enjoyed? And if they had others where they started out and they stopped, why did they stop? Was it pain? Was it boredom? Did they just hate it? What kind of things resonated with them? We want to know about environmental barriers and resources. Do they have a gym in their building? Do they have access to a Y? Do they have home exercise equipment? Do they live in an area with a park nearby or sidewalks? What is their sort of like financial constraints in terms of investing in fitness? And a fitness program. So our goal is really that from the get-go, we want to find actionable, realistic, practical ways that we can weave exercise into their day. We want to discuss with them their readiness to change and any motivational factors, and also take a look at their family history. We use the ACSM, American Heart Association, risk stratification algorithm when we start with people, just to determine if there's any need for any further screening before we start with them, whether they need clearance from any stress testing or anything like that. And then we go to our first step is a baseline fitness assessment. And that has many benefits for us. It provides us comparison to age and gender normative data. So we kind of get a sense of where does this person fall in relation to their peer group as far as measures of fitness. We can identify each individual's strength and areas of opportunity for improvement, because everyone has areas of strength. So we want to make sure we point those out to people. And it gives us the basis for appropriate and specific exercise prescription. And it also gives us a baseline for measuring progress, which was really motivating to our clients when we can compare them to their initial assessment to how they've progressed. So at HSS, the group of exercise physiologists have created this performance pyramid, which is really the lens through which we look at all of our clients. The key concept is that most higher level activities, whether that's a sports specific activity or just whatever some person's individual goal is, that they're able to pick up their grandchildren or walk around the block without pain or whatever it may be, those higher level tasks are supported by an underlying foundation of some basic categories of fitness, such as postural alignment, dynamic and static alignment, flexibility and joint range of motion, strength, cardiovascular fitness, and a well-nourished and well-rested body. So if any of these pieces are lacking, then there's a good chance that either an injury might occur, someone's not going to be able to do what they are hoping to do as far as reaching their goal, or they're going to have sort of compensatory movement patterns that might be detrimental. So that basis of the pyramid is kind of on top of that, are all the higher level tasks that we build up to. So our assessment is essentially an assessment of the baseline of the base of that pyramid. So when we look at postural alignment, we look at both static and dynamic alignment. So we'll have people stand in front of a grid and take a picture of them, all four sides. And the purpose of that is just to see if there's anything in just the way somebody holds themselves up against gravity that we need to address before we think of having them move rapidly or load that posture. So whether, there are asymmetries or protracted scapula, or just things that we need to keep in mind when we're thinking about what appropriate exercise would be, we want to point that out. We want to get a look at that right off the bat. Then if we're looking at dynamic alignment, we look at common movement patterns and how people perform them. Squat, hip hinge, push, pull, and just see if there's anything we need to clean up in these movement patterns before we load them with like resistance or with more rapid movement. And there are various tools we have, from functional movement screens and selective functional movement assessments and balance assessments, that we can use to really quantify, put a number to how well somebody's moving. For joint range of motion and flexibility, where there's a ton of different tools we can look at, from goniometer measurements to mass sort of sit and reach, and getting an idea of where people fall in terms of mobility. And then for muscular strength and endurance, again, we have a lot of tools in our toolbox to look at that. Some of the tools are more appropriate for more fit, active people, whereas we have things for the frail, elderly population, such as timed up and goes and hand grip assessments and 30 seconds chair sit to stands. Those are all things that we can use to get a sense of muscular strength and endurance. And then for body composition and sort of lifestyle and nutritional status, we can do skin fold measurements. We have a DEXA scan at HSS. So we have opportunities where we could actually measure body comp. But when we discuss this with our clients, our real focus is on the importance of changes in body composition, whether we focus more on bone density and muscle mass, and that those type of changes are going to require that you have proper nutrients, and that you also are getting enough rest and recovery and sleep. So you can have the best training program in the world, but the adaptations occur during recovery. They don't happen during the training session. The training session is the stimulus, and the adaptations occur in the recovery. So if people are, training like crazy, but they're not sleeping, they're completely stressed out all the time, and they're eating crap, they're really not going to be seeing the gains that we want to see from a nice training plan. And then finally, cardiorespiratory fitness is kind of the underpinning to all of this. Any amount of activity is going to be determined by what your baseline level of cardiorespiratory fitness is. So, this is back to your high school biology, but just to remind everyone of kind of what we're looking at when we're talking about cardiorespiratory fitness. This is the typical graphic that they show for this, which is like at the onset of exercise, it's those anaerobic pathways that are providing the energy, and then you are more into aerobic pathways of glycolysis and lipolysis. But I think the big takeaway from this graphic is that they all overlap. So truly in the course of your day, all these energy systems are at play. So if you're walking down the street, crossing the street, and the light's changing, and there's a guy on a bike messenger barreling towards you, you may be in aerobic lipolysis when you're start walking across the street, but you're going to be in those anaerobic pathways when you're jumping out of the way of the cyclist. So they are all kind of going at all the time, but really any sort of sustained activity, you are relying on those aerobic pathways to provide the energy for that. So we determine cardiorespiratory fitness is really the ability to perform large muscle, dynamic, moderate to vigorous intensity exercise for prolonged periods of time as a measure of the aerobic capacity. And the way we measure aerobic capacity is by VO2. So VO2 is simply the volume of oxygen consumed relative to weight. So if you were to look at somebody's VO2 asleep, typically you're going to be using about 3 to 3.5 milliliters of oxygen per kilogram of body weight per minute, just doing nothing. And then if you got up and started walking, you're using 10 milliliters of oxygen roughly per kilogram per minute. And if you were planning on winning the Boston Marathon on Monday, you would want to be able to use oxygen at the rate of about 70 milliliters per kilogram per minute. So every activity has a cost in terms of how much energy, how much oxygen it's going to take to produce the energy aerobically to fuel that particular level of activity. And we all kind of are the same in terms of how much oxygen it's going to take us to sleep or how much to walk. But we do kind of differ at where our endpoints are. And so that sort of consistency of the oxygen cost of different activities is what they use when they're talking about METs. And some of you may be very familiar with MET charts. But basically 1 MET is resting oxygen consumption. 1 MET is 3.5 milliliters of oxygen. So if you look at a chart that's just quantifying, a list of 5 MET activities, it means that, those are all those activities cost the same amount of oxygen to produce the energy to do them. So it's an easy way to kind of get a sense of what is the actual cost of different activities that are maybe look different, but have a similar oxygen cost. So now if we think about what maximum VO2 is, and that's just where we hit our limit in terms of oxygen consumption, it's the most amount of oxygen an individual is able to use during exhaustive exercise. And it is going to be dependent on healthy lungs. The oxygen has to be able to diffuse across the pulmonary membrane. And then your hemoglobin is going to pick that up. Your heart's going to pump that to your muscles, and your muscles are going to extract that to use in energy production for whatever activity you're doing. So what determines your max VO2? And largely genetics. I mean, genetics play an enormous role in just what it is at baseline. But the other thing that's tremendously genetic is your ability to adapt to a training stimulus. So there are people that we call non-responders. You could train forever and nothing ever gets better. But on the other side of the coin, people who have a very significant response to a training stimulus and can get up to 50% improvements in their aerobic capacity. So there are significant improvements possible in most people. But we do kind of vary in terms of where our endpoints are. So you have this wide spectrum of people who, let's say, have significant cardiorespiratory disease and may have max oxygen consumptions of under 20 milliliters of oxygen. And on the other side of the coin, you may have people who are very determined, dedicated recreational runners and are getting their VO2s up into the 50s. So VO2 is simply determined by cardiac output times AVO2 difference. So if we look at just averages, if we look at average levels, we look at average healthy 30 to 39-year-olds, max VO2s in men is going to be in the low 40s, and the women are going to be in the high 30s. And then as you can see, if we look across the spectrum of age, that as you age, you can see those numbers drifting down. So by the time a male's in his 70s, he's down there about 30 milliliters. And then you can also appreciate what true outliers, elite endurance athletes are, who have maximum oxygen capacities of 60 to 80 milliliters of oxygen per kilogram per minute. And at the other end of that spectrum are those with oxygen capacities that are under 14 are generally heart transplant candidates who really have such a limited ability to take up and use oxygen. So once you know someone's max oxygen consumption, if you know their aerobic capacity, you have a pretty good idea of how they're going to do in any given activity. You know what they're capable of. So we know that an 11-minute mile takes about 33 milliliters of oxygen. We know a 10-minute mile is about 35 milliliters. When you're getting down to a 9-minute pace, you're getting close to a 40 milliliter cost. And then as you can see, the pace that Shalane Flanagan ran when she won the New York City Marathon required an oxygen uptake of about 61 milliliters of oxygen per kilogram per minute. So a lot, and that is just where I work. That's one of the athletes we were testing down there. So once you know kind of somebody's max capability, you know what they're capable of. And as you recall from that previous slide, the average healthy 30-year-old guy is going to have a max VO2 in the low 40s. He's not running a 3:30 marathon. That requires 43 milliliters. Nobody's running a marathon at max. So when you see those numbers, you have an idea of how somebody's going to do. So this explains why the average marathon time kind of globally is what it is. In New York City and pretty much consistently across the globe, the average marathon time for is about 4:28 for men, and that's about a 10-14 mile. So that's got an oxygen cost of about 33 to 34 milliliters per kilogram per minute. If you figure the average guy has a max oxygen capacity in the low 40s, mid 40s, they're going to be running a marathon about 75% of max. Makes perfect sense that they would be finishing in about 4.5 hours. And like I said, that is pretty true globally. If you compare men and women, it is very consistent with what about 75% of an average max VO2 is. So once you know somebody's aerobic capacity, you really have a very clear sense of what kind of activities they're going to be able to sustain. And this is just to show all the different ways, all the different things that play a role in your aerobic exercise performance. So not only limiting it, but also the areas of opportunity for us to find ways to create adaptations that are going to improve somebody's aerobic capacity and functional capacity. So if we look simply at the sort of pulmonary ventilation, aeration, minute ventilation, arterial oxygen saturation, all these sort of things are going to come into play there. And then centrally, your cardiac output, arterial blood pressure, oxygen transport capacity are going to play a role there. When we look at the peripheral blood flow, we need to think about, are their muscle blood flow, arterial vascular reactivity? What's the capillary density like? How is that? Are they able to feed oxygen to those working muscles? Their vascular conductance, their hemoglobin oxygen affinity, their venous compliance and reactivity, all those things will play a role. And then at the muscle level, there needs to be enzymes and oxidative potential to take up and use that oxygen. Energy stores and substrate availabilities are going to have an effect. Myoglobin concentration, mitochondrial density, muscle fiber type, all of these things are playing a role in either limiting or really maximizing somebody's aerobic exercise performance. So if we just kind of break down those components, what does training do to these different steps along the way? So if we look at just pulmonary function, endurance exercise really has no measurable effect on lung structure or resting pulmonary function. If you looked at a completely unfit person and an elite athlete sitting in a chair, they're both breathing about 8 to 12 times a minute. You would never know the difference. And same thing when they're working at absolutely maximum level, they're going to each be breathing at about 45 to 60 breaths per minute. So in terms of respiratory rate, you really don't see a whole difference in trained and untrained, but the respiratory muscles do respond to training. They become stronger and more fatigue resistant. So in an untrained individual at max effort, they're going to be moving about 70 to 90 liters of air in and out of their lungs per minute. And trained athletes, you're going to see upwards of 100, 150 liters per minute at their max efforts. When we look at cardiac adaptations, so sort of morphological significant changes that occur to the heart over time with training, and you can see these reflected in these numbers. So this table just looks at sedentary men, pre and post training, as well as world-class endurance runners. And if we look at the resting values, if we just look at resting heart rate and resting stroke volume, you can see that significant drop in resting heart rate with the concomitant increase in stroke volume. So they're just delivering more blood with each beat, so they don't need as many beats. Then if we look at the maximum levels, max heart rate, you can see this drift as from somebody who's sedentary and unfit to a very fit person. You may see a little drop in that max heart rate. And that's usually just because a bigger heart takes longer to refill. So the max heart rate may drop a couple of beats. And you can appreciate from the stroke volume and the cardiac output this significant increase in all of those parameters. So stroke volume going from 120 to 140 to 200 in elite athletes, and the cardiac output from 22 liters per minute in a sedentary male all the way up to almost 35 in elite athletes. And the capacitance of the heart is clear in terms of volume. When you see a sedentary guy, the heart's going to hold about 750 mLs of blood, and then upwards of a liter in an elite endurance athlete. So truly that heart just changes shape with training. This slide is really just taking another look at that. But here we're looking at a volume, the effects of volume versus pressure overload on the heart. So this is looking at the percent differences in heart size between runners, cyclists, endurance athletes, and strength athletes, weightlifters, versus sedentary controls. So if we just look at left ventricular internal diameter, you can see the cyclists and runners have a fairly significant increase, 15 to 16% over a sedentary control, with a small increase in the strength athletes. If we look at the mean wall thickness, again, you can see the endurance athletes have a slightly greater increase in wall thickness compared to strength athletes. And then when you just look at the left ventricular mass, you can see the difference effects of volume versus pressure overload. That's 50 to 55 to 65% greater left ventricular mass compared to sedentary controls in endurance athletes versus a significant but less increase in strength athletes. So all of all these forms of exercise do affect the heart, but in different ways, and certainly the aerobic athletes have a much greater change in cardiac changes. Well, what about red blood cells? And this is where everybody cheats, and for good reason, it works. 1 gram of hemoglobin carries 1.34 milliliters of oxygen. So the more hemoglobin you have, the better in terms of your aerobic performance. So if we look at how much oxygen is carried in 100 milliliters of blood, you can see in an average male or female, you're looking at that 17 to 20 range milliliters. With blood doping, you can get that up a lot. And if you look at that graph of the average speeds in the Tour de France when doping was rampant, you can appreciate what enormous performance enhancement you're capable of achieving with doping. So not that I would advise doping, but what I would say is that it's something to be thinking about with anybody who's doing some endurance training, is that they have adequate iron intake, because not only hemoglobin, but many oxidative enzymes contain iron, myoglobin certainly. So you just want to make sure they're getting adequate iron. We've had instances where, women who have heavy periods and are vegans are training for a marathon or an Ironman, and really they're feeling a little, not hitting the targets they'd like to hit. And sometimes it just has to do with simply they're just a little bit down in terms of their iron stores and their hemoglobin levels. So definitely something to be mindful of. And then if we think of muscle fiber type, so we all are kind of a mix of, fast twitch, slow twitch, these different muscle fiber types. And people who excel at long distance running are probably just genetically, they have a greater preponderance of the oxidative muscle fiber types versus, your power athletes, where they're just going to be genetically gifted with a lot of type 2B muscle fibers. So we all have kind of this mix, and they do have very different qualities. So if we look across the spectrum from type 1 fibers, which are your slow twitch, low power production, very fatigue resistance, tons of capillary density and mitochondrial density. They don't generate a lot of force, but they last forever, and they can metabolize fats for fuel. And then you work across those type 2 fibers from the 2A, 2X, and 2Bs. They get progressively less they get progressively more fatigable, but higher power outputs, and anaerobic in their nature. And the thing to keep in mind about all those type 2s is that they are, they can be convinced to be a little more oxidative. So this is just a indication of what can happen to those very anaerobic glycolytic fibers if they're exposed to training. So if we look that the y-axis is citrate synthase activity, which is an oxidative enzyme, and then the X is just minutes of training. So if you want to increase the oxidative capacity of those type 2 fibers, you have to recruit them. So that's where working at a pretty higher intensity, you need to recruit these muscle fibers that are going to generate more force to get you pedaling a bike harder or running faster. But if you can sustain recruiting those fibers for sustained amounts of time, it does provide a stimulus for an increase in oxidative capacity, which is ultimately going to allow you to do harder work for longer periods of time. So, and this is where muscular adaptations, I think, are so important, is that with training, you can see in 6 months a 25% increase in capillary density to working muscle. Mitochondrial density is going to increase significantly, of course, depending on what muscle fiber type. You'll see more in obviously slow twitch fibers, but you'll also see an increase in glycogen and stored intramuscular fat, and massive increases in oxidative enzymes over time with training. Again, it will vary depending on muscle fiber type, but I think the thing that's important about that is that if you have a client or a patient who's got heart failure or significant cardiorespiratory disease, where their ejection fraction isn't going to get better, the cardiac improvements are maybe not going to be possible in this person, you get these adaptations at the muscle level, and you can improve their functional capacity and their quality of life quite significantly, despite not seeing a real change in terms of cardiorespiratory function. Next, let's just talk about lactate threshold, which is simply the point during exercise of increasing intensity at which lactate levels begin to rise disproportionately. That typically occurs at about 50% of max in untrained people, and it's super trainable. You can raise that up to 85 to 90% with training so that people can sustain a higher percent of their max capability. It's an excellent marker of maximum sustainable workload. So when we look at that, first of all, just to dispel all the common comments about lactate, it's not a waste product. It doesn't cause a burn. That's caused by the high temperature in the muscle. It doesn't cause muscle soreness. That's little micro tears. It doesn't cause fatigue. That's the dropping pH in the hydrogen ions. And it doesn't linger in muscles for days. It's within 30 minutes of even the most strenuous exercise, you've cleared the lactate. It's shuttled to your heart, your kidneys, inactive muscle, and liver for use as a fuel, and it's a gluconeogenic substrate for glycogen synthesis. It gets blamed for everything, but it just hangs out with a tough crowd. It is not the cause. But when we're testing people, this is kind of what we look at. So this one is the first graph is of a cyclist, the other one's a runner. But essentially, we just take a measure, a blood sample at each stage of exercise, and measure their blood lactate levels. And you'll see, we look at, first of all, how low is it? How long does that curve stay flat? Once it starts going up, how steep is the curve? And how long can that person last in the presence of accumulating lactate and a dropping pH in the muscle? So those are kind of the ways we determine, where we're going to train people. So we can use those numbers very effectively to create our training zones. So that the blue is the lactate, the red is the heart rate, and the x-axis is the watts on the bike. And you can just determine based on that lactate curve, okay, I'm going to have them doing their extensive aerobic base training, and at that wattage and heart rate, I'm going to have them working where that lactate starts drifting up a little bit. Threshold is right where the breakaway point occurs, and then anaerobic tolerance levels are up there where you're seeing that rise, and finally the power efforts are at that high end. So how do we test this? Well, we at HSS, we have a metabolic cart, and we do use that for hooking people up and taking lactate levels at each stage of the test. Gives you a wonderful data, very accurate data, and very precise training zones. Certainly some places, I don't know if Columbia Prez or Cornell has one of these with an EKG setup for diagnostic purposes, but certainly that's something you see in some labs. So it's great, but obviously it's a little expensive, and it's not for everybody. So more often than not, you'll get a client who may have had a stress test, and you can use that to determine aerobic capacity. It's not ideal, but it'll do. A standard Bruce protocol has, the MET levels associated with each stage. So you can extrapolate from what MET level they achieved, what stage they achieved on the Bruce protocol, what their aerobic capacity is. The downside of the Bruce protocol is that it's great for cardiac stress testing because they keep the speed so slow so that the person isn't really running and jiggling and causing artifact on the EKG, and they use incline to get the heart rate up. But it becomes mechanically totally uncomfortable. So people end up holding, because it's so steep, they hold on to the edges of the treadmill. And then basically that, you don't get an accurate estimation of their fitness, because that's just holding on is reducing the metabolic cost of the workload by quite a bit. It's often many cardiologists also terminate stress tests at predetermined endpoints, about 85% of age predicted max. Age predicted max is notoriously unreliable, so it can often underestimate fitness. And there are also enormous net jumps. So you're going from significant increases in workload. So many people kind of just have leg fatigue. We have other ways of measuring, which is submaximal tests that are cheaper, easy to do, and don't require somebody to go to a max level. Field tests where you have somebody
Hey,
either
Jan, hold on a sec.
where you have somebody go either a certain time or distance, and you see how far they go in that time or how quickly they cover a distance, and you can stratify fitness that way. There are simple things like 3-minute step tests where you get the recovery heart rate, and that will tell you how fit somebody is. Those obviously require a certain baseline of fitness, because walking up and down off a 12-inch step to a metronome requires at least a VO2 of 26. So that can be kind of challenging. And then we have submaximal exercise tests where you just have somebody on a bike or a treadmill and you have 3 workloads, get them to a steady state heart rate at each. And from that, you can plot out what their max might be, just in kind of like a regression equation to see where they'd fall. These are pretty good in terms of accuracy. And the nice thing about them is that you can also see your client at different intensities of exercise, measure their rating of perceived exertion, their blood pressure, kind of see how they respond to different workloads. These tests can come in super handy as far as not only diagnostic tools, but also to stratify fitness level and provide a basis for very individualized training zones and exercise prescriptions. They're great in terms of baseline data for comparison down the line, and also to just teach people, like, what does it feel like to be working at a 50% of your max? How does that feel to you? And they understand different intensities of exercise pretty well. Now let's just talk about body composition. And here at HSS, we do have a DEXA scan. We can do skin folds, but we're really talking about lean mass versus fat tissue. And lean mass encompasses bone, muscle, blood, bodily fluids, organs, and connective tissue. And those are kind of the things that take up and use oxygen versus fat, which is more of a storage. But a DEXA scan obviously really details it from each arm and limb to the head, how much lean tissue and how much fat and so forth. But what we usually try to stress to our clients is we're more obsessed with like muscle mass and bone density, because fitness, you can come in all shapes and sizes and be fit. So body fat alone is not really a great measure of somebody's fitness. But where it does come in handy is when you are working with somebody who, let's say, is losing body fat. There's going to be a concomitant change in their perception anyway of their max VO2. So here, just as an example, you've got a 30-year-old guy, he weighs 170 pounds, 20% body fat. If we do a max VO2 test on him and find that he has an absolute VO2 of 3.2 liters, meaning that was as much oxygen as he can take in, and divided by his current weight in kilograms, that gives us a max VO2 of 41 milliliters of oxygen per kilogram per minute. Well, he's, what takes up oxygen? It's muscles and organs and so forth. So let's say he loses 10 pounds of body fat, he gets down to 15% body fat. His absolute VO2 has not changed, but now his max VO2 has shown a 7% improvement. He's up to 44 milliliters of oxygen per kilogram. He will perceive a difference in terms of what he's able to do, how easy certain activities feel to him. So even without a change in actual VO2 max, you will perceive an improvement just by losing body fat. And we certainly see that in clients, and they definitely appreciate feeling like they have more energy. So basic training principles, we think of training specificity. Training adaptations are specific to the type of activity and the volume and intensity of the exercise performed. Heredity plays a major role in determining not only what degree training adaptations will occur, if they will occur, and how quickly, and progressive overload. We know we have to gradually increase training load, volume, intensity, frequency, type of exercise in order for ongoing adaptations to occur, but it's sort of a dance between progressing and avoiding injury. So that's part of what we keep in mind. So just to give you a quick case study, Melanie was a 49-year-old sedentary small business owner. She worked out of her apartment. She was 5'5", 208 pounds, 33% body fat, so obese by BMI. She was hypertensive. She had a relatively high resting heart rate. Her family history, dad had a heart attack at 51 and her mom had hypertension and type 2 diabetes. So she had this episode of shortness of breath and chest pain at home and went to the emergency room, fearful because she was 49. Her dad had had a significant event at 51. She was terrified. They found nothing wrong when she went to the emergency room. She was referred to a cardiologist who did a workup and said, everything's fine. You had an anxiety attack. She completed stage 2 of the Bruce protocol and she was advised to begin an exercise program. So when she came to us, her max VO2 was 25 milliliters per kilogram, which is in the 15th percentile for women in that age group. And as far as strength, she had very little core strength. She couldn't hold a plank. Her upper body strength, she couldn't do even a modified push-up. She had very little hip strength or legs, lower extremity strength. She couldn't hold a bridge. We did a functional movement screen, which is just an assessment of quality of movement. And the max score on that is 21. And scores of 14 and under are associated with higher rates of injury. So she scored 12 on that FMS. She was also hypermobile, which is like the kiss of death, the bad combination to have lax, loose joints and no strength to stabilize them. So that's a perfect setup to get hurt. She worked long hours. She had no time to exercise. She had had a history of bad experiences with exercise. She was hurt by trainers. In group exercise classes, she felt inadequate. She didn't like the gym. She had nagging low back pain and bilateral anterior knee pain. So with her now, actually, this was pre-COVID, so now we would have advised some virtual training with us. But at the time, we just came up with a plan for some home exercise. So she had a stationary bike at home and she also liked walking. So we made a deal with her for 3 sessions a week, didn't have to be long, just get them in for 2 weeks to just establish a pattern, a habit of exercising. And then if she was able to do that, to progress to 4 sessions per week. Her cardio sessions were completely rating of perceived exertion based. She did base work, base comfortable effort on a scale of 1 to 10, like a 5, 6, and then we'd have some tempo workouts. So she had 3 different workouts to do each week, a base workout, a tempo workout, and then some short high intensity intervals. We gave her body weight exercises, planks, side planks, modified push-ups, chair squats, step-ups, and a band for some monster walks. And she had a foam roller at home, which we advised her to use if she had any soreness. She came back 4 months later and she'd gotten a Peloton and she was exercising 3 to 6 times a week. Her husband had started exercising as well. She'd lost 12 pounds. Her body fat was still, high, 29%, 30th percentile for women in her age group, and still considered obese by BMI. But her blood pressure had come way down. Her heart rate had dropped to 78 beats a minute at rest, and her max VO2 had come up to 33 milliliters, which now placed her in the 50th percentile for women in her age group. She had no back or knee pain. She was able to, her core strength had improved to the point where she could do a 60-second plank and side plank. Her upper body strength had improved, overall strength had improved tremendously. Her FMS score, the quality of her movement, had now improved up to a 17 out of a 21, and she was training for a hiking vacation for her 50th birthday. And now just looking at sort of the hard evidence of what had happened, you can see this functional capacity change. So this is simply looking at her heart rate at different workloads, and you see that significant change. I mean, at a 4 MET workload, her heart rate was 146 and it was down to 139 just 4 months later. And same thing, you can see her max heart rate was 174 beats per minute, which she hit at an 8 MET workload originally, and was up to a 10 MET workload before she hit that heart rate when she came back to see us 4 months later. So I think the key here is that we have a very systematic way that we look at fitness and we look at the individual and we try to figure out, like, what are the pieces of that puzzle? Where are they at right now? And what can we do with them to create a plan that is going to put those pieces together in such a way that they will be able to achieve whatever their individual goals are without getting hurt, and also hopefully having fun and doing something that resonates with them that they'll want to keep doing, forever. So that's my take on exercise physiology. So if anyone has any questions, just let me know.
That was great, Polly. Thank you so much.
You're welcome.
I am going to call on Dr. Lucas for a question because I know he's been listening to Peter Attia podcasts and probably has. I bet you it's a question about lactate.
I can occupy the remaining 10 minutes with questions. So I'm gonna try to just ask one and give the floor back to the group here. So I guess, let me see. Do you use any like blood flow restriction training with any of your patients? Is that something that I mean, the data behind it seems pretty strong where you're able to use less weight and do it for less time. It seems like it's maybe a little uncomfortable, but the benefits even at doing it with a lesser weight and lesser time exceed the benefits of muscle growth when exercising for weight training normally, number one. And number two, it seems like there's decreased risk of injury by virtue of using the lower weights in that with that type of training.
Yeah, we definitely use it a ton. I don't use it as it's much more of a rehab tool, to be perfectly honest with you, because you know, we use it with some arthritis patients and so forth. But yes, they use it a ton with like after ACLs, after like any of that stuff, so that you can get that muscle working without loading the joint. So we have BFR everywhere at HSS. It's all over the place.
Polly, can you explain what that is exactly, how that works mechanically?
Well, basically what it does is it's like putting a blood pressure cuff on, let's say you were trying to work your quads or whatever. You put this cuff up on the top of your thigh, and the system we have at HSS, you could actually just tie a tourniquet around your thigh, which some people in these muscle gyms do. But basically ours it measures flow. So you're trying to cut off the blood flow, not entirely, but you're trying to cut it off so that there's very little flow into the muscle. And then, so what happens is that all those metabolites start accumulating. So you're just getting like crazy levels of metabolites with very little actual load. You just do it's like 30 repetitions, you take a break, and then you do a ton of repetitions with really either body weight or very light loads. And it's your muscle thinks it's being worked to fatigue because the pH is dropping and there's, all this lactate and so forth. So the muscle thinks, my God, I must be like doing 1,000,000 reps with 1,000 pounds. And so adaptations occur. The downside is that you're not exposing connective tissue and ligaments and bone to load that you would be in a normal strength training session. So they typically want them eventually to not be using BFR because you want to expose your body to the loads that it may be exposed to in sport or and that the connective tissue and the bone and so forth gets exposed to those type of actual mechanical loads. But it's super useful for people who have joint pain or who have just had some kind of surgery, and you're trying to get, people with like who are dislocators, those patella patients where their quad is just not firing, and you can really kickstart it with BFR. So it's a really great tool. And it's not for everybody. Also, to your point about it being uncomfortable, there are certain people who don't want exercise to be uncomfortable. They're not that kind of head, they don't have that kind of, so you have to, some people, they'll do it and they'll be like, this is not for me. I am not doing this again. So it really depends. But if you have the nice match of a motivated patient, the right person, it really is very, very, very effective.
What kind of cuffs do you use?
Delphi, we use the Delphi system.
Delphi, okay. All right. Okay.
Does anyone else have any other questions?
Yeah, hello.
Yes.
Hi. You hear me?
Yes,
Yep.
we can hear you.
Yeah, thank you for the presentation.
Wait, I'm sorry. No, you just
Now
cut out.
Okay, so my question, how well could use it for exercise prescription?
I'm sorry, Salah. We still can't hear you.
I do
Mic
know.
seems to be
Type it in
going
the
in and
chat.
out. You can put it in the chat and I can read it out loud if that might be.
Sure, sure.
I guess while Salah is putting that in the chat, Dr. Lucas, did you have more questions? I know you do.
I've seen in multiple places, I think there's been multiple studies showing like grip strength being associated with longevity. Is that something that you test and like retest over time to kind of see if it's improving, or how do you bring that up with patients or incorporate into your approach?
Yeah, we do. We have a hand grip dynamometer, and we'll just get it at baseline, and then we can compare them to norms and so forth. It kind of, again, you've got some people who have like arthritis in the hand, and there's various reasons people can't do the hand grip very well. But yeah, we definitely use that as just another measure, another way. We're always looking for ways that we can show, as seeing changes in the mirror takes a long time.
Yeah.
And so anything we can do, whether it's look, your heart rate's so much lower, look, your hand grip's much higher, all those motivating things where you see that the work you're putting in is paying off. Anything we can measure that we can then show them is getting better is a great tool, and that's one of them.
Okay, perfect.
Okay, it looks like Salah was asking how do you prescribe intensity? Specifically, like what tools do you use in the exercise prescription to prescribe progressive intensity?
Yeah. Well, that varies. So some people, like I said, some people you're just going to stick with a rating of perceived exertion. One thing we do when we're testing, aerobic capacity is ask at every stage, how does this feel to you? And some people are pretty spot on. I mean, their number, if you look at what's happening physiologically, they can feel it. Other people, it's like on a scale of 1 to 10, they're like 2, 2, 2, 10, like they have or they're giving you an 8 when they're barely working. So, but generally that can be a very easy tool if people don't want to get involved with gadgets and heart rate monitors and, that kind of stuff. So RPE is one. Another is heart rate. When we know their heart rate zones, we know what, working at 80% of your max is, we can prescribe that. We can use workload. So if we know that somebody's max effort if they want, like, for example, intensity on the bike, and we know their wattage for their max, for their peak output on a bike, we can use that. Pace and running. And then as far as like for strength training, again, we're looking at, generally we'll tell people, you want to be able to do somewhere, and when we're starting out, that sort of 8 to 12 repetition range, but regardless of repetition, by that last repetition, you want to be ready to stop. If you could do the same, if you could keep doing another 10, you need to go up, or you need to slow down, or you need to do full range of motion, whatever it is. Like, in order for it to be effective, the stimulus for your muscle to get stronger is fatigue. So if you're not feeling some sort of muscle fatigue at the end of a set of strength training exercises, then you need to either reevaluate the exercise, the load, or the pace at which you're doing it. So we use different methods to give people an idea of intensity.
So people should be sore after their workout.
No, they don't have to be sore. No, they don't necessarily have to be sore, but they have to be, if you're lifting weights, you don't always get sore. More, it's when you're doing a lot of eccentric work, meaning, slowly lowering a weight, you're going to probably get sore from that. But if you're doing a lot of sort of heavy concentric lifting, you probably won't be sore from that, but you should feel good and tired by that last rep. It doesn't have to be where you're like dropping the weight and shaking, but you want to be like, you shouldn't be able to be thinking about like, I'm going to do my laundry. What am I going to have for dinner? Like, you shouldn't be able to be thinking about a million other things while you're doing those reps. You should be like, this requires my focus to maintain proper form and control of the weight through the full range of motion. So that's sort of a load where it's like, you're not just, going through the motions.
Great. Do you have a couple more minutes for one more question? Go ahead, Dr. Lucas.
Well, so I mean, we're a weight loss group of providers, so most of our patients are going to be trying to achieve a caloric deficit. I guess the question is it? I mean, how much my understanding is that you can still build some muscle while being in a caloric deficit. Maybe not everyone, but some people can. Do you recommend them to try to? How much protein would you recommend for them to try to aim for in terms of consumption per day?
Well, we try, I mean, one of the things we are very sensitive to is staying in our lane when we're working with these patients, because many of them are seeing a dietitian. The other thing is that most, I would say, not just people with weight loss issues, but a lot of people in general have had terrible experiences with exercise and trainers and fat shaming and, you know, feeling inadequate. And, you know, so I feel like the diet part of it is a loaded area to get into. So we try, because really, truly, most of them say they're working with somebody, with a nutritionist or registered dietitian. So we don't want to also give a mixed message. So we try to just give, this is what's, you know, and that's sort of that general thing where we talk about how do you build muscle and bone. You have to have adequate nutrients to do it. You have to have, and this is something to talk to your dietitian about. If you're going to be training, like in order to make your bones strong, you're going to need calcium. In order to build muscle, you're going to need protein. And so we try to sort of make that very strong impression that this is really key, that they're fueling appropriately and getting adequate rest. And but we don't want to step on toes, and we also don't want to make them think that we're the food police. We're just the exercise people.
Perfect. Okay, great. Well, with that, Polly, I think we'll end our session tonight. Thank you again for sharing your expertise and giving us an intro to exercise physiology. It was very stimulating.
Well, thank you for having me.
We'll
Come
catch
on
up
over
soon.
sometime and let us torture you.